a group of 4 vascular surgeons, myself included. You'll hear a name, Dr. Sharma in the community, Dr. Dunsing in the community, as well as Dr. Deering in the community. And periodically, if you come back to see this webinar more than once, oftentimes they will also give this the same talk. So today, I'm excited to talk about one of the bread and butters of our vascular surgery world. Vascular meaning blood vessels, is carotid disease. And what the carotid is an artery that's in your neck. It feeds your brain and causes trouble. And so today we're going to go through the nuts and bolts as if we have an office consultation. We're going to talk about the disease, the anatomy, what is the risk, why is it a problem, and what is it that we do as surgeons to quote unquote fix these arteries. So Chelsea, let's move on to the first slide. So what we're talking about here is the carotid artery, and the carotid artery is the main blood vessel of which there are 4 that supply the brain. And the carotid artery is normally the size of maybe your small finger, and it comes off of your aorta, which is the main blood vessel inside of your chest that comes outside of your heart. And it pumps artery flow with each heartbeat and feeds oxygen to your brain. The carotid artery is on both sides of the neck. There's one on the right, one on the left, and it's on the front side of the neck. And the artery splits in 2 at about the level of the chin, maybe a little bit lower, in which the internal carotid artery is the vessel that provides direct flow to the brain, and an external carotid artery provides blood flow to your face. And it's that internal carotid artery that gives us the trouble. That's what we're talking about here. So here's a photo of the carotid artery cut away in half. And that yellow material there is what we call a fatty plaque. And this fatty plaque can spontaneously give us trouble in that it pieces break off and it travels downstream and lands in the tiny arteries in your brain. Chelsea, next slide. So what happens when that little tiny particle breaks off from the plaque at your carotid artery, at your neck, and travels all the way up into your brain? It gives you what's called a stroke. And a stroke, we like to use that word because it's commonly known and understood. But what it really is it's a blockage of blood flow, artery blood flow, oxygen blood flow to the brain, and such that that part of the brain is robbed of the blood flow and it dies. Well, we're familiar with something like that in other arteries or in other parts of the body, like namely the heart, in which a piece of plaque travels down the artery within the heart and it blocks off the muscle of the heart, and you get what's called a heart attack. Well, similarly, the stroke is the same thing, but simply of a different artery. And so another word that we use for a stroke would be a brain attack. So if you hear the 2 different words, those are one and the same. So what is it that we're talking about here? We're talking about strokes and blocked arteries. And well, what is the problem with it? Well, there's a risk of stroke with these blocked arteries. And since stroke deprives your brain of the oxygen, like I described earlier, it only takes minutes for brain cells to begin to die. Brain cells are very sensitive to lack of oxygen, just like your heart muscle. I would say even more sensitive than your heart muscle. And every year, 15 million people worldwide suffer a stroke. Nearly 6 million die, and another 5 million are left permanently disabled. So you can die from a stroke in which your brain dies and you stop breathing and you die. Or, and some would argue even worse, you suffer a major debility, a permanent disability due to this stroke. Carotid arteries is only one of the many causes of a stroke, but it's estimated to be the source of a stroke in up to 1/3 of all stroke cases. So it's a big component of folks who have stroke. So let's say you come in through the emergency room, or a friend comes in through the emergency room, and you have a stroke. One of the most important things to look for, other than taking care of the brain immediately, is to get a study of your carotid arteries to see if that's the cause of your stroke. 427,000 new cases per year. So let's go back and let's talk about that carotid stenosis. So I talked about that word fatty plaque, and that fatty plaque narrows that artery. And it's not just the fact that the artery is narrowed, that the blood flow is limited. It's more the fact that that plaque can become unstable, break off, and travel into the brain. Carotid arteries, go back, Chelsea, please, go back. Carotid arteries, vital blood flow, right? Delivering oxygen to your brain. And this blockage, again, that fatty plaque occurs when the blood vessels become clogged with hardening of the arteries, with cholesterol and disease over time. And then when that plaque builds up, again, we talked about that vessel begins to narrow, slow down the blood flow, and then that plaque can break off and fragments travel to the brain. Go ahead, next slide. So how do you diagnose this disease? You know, well, boy, doc, that sounds really alarming. I want to know if I have this disease. So how do you diagnose it? Well, excuse me. Luckily, the carotid artery blockages, it develops slowly over the span of someone's lifetime, tens of years. And often they develop without any symptoms. Again, what are the symptoms of carotid blockages? A stroke. And oftentimes your first symptom is a stroke. Your doctor can screen patients using a non-invasive test called an ultrasound. It's a probe that's placed up against your neck that is done at radiology imaging departments. And it measures the blood flow and takes pictures of that artery at that division at the base, at the middle of the neck. Sometimes a significant blockage can even be heard. You can even hear that with a stethoscope. So oftentimes your doctor, or should I say sometimes your doctor, can put a stethoscope up to your neck and even hear the rushing sound of that artery when it's narrowed. We call that a bruit, and that's caused by narrowed blood flowing through that blockage. But often in some patients, the first sign or the presence of this blockage is simply a stroke. And we talked about earlier, when a patient's admitted to the hospital with a stroke, one of the most important things that we need to do is to look at these carotid arteries and see if this is the cause of that stroke. Okay, next slide, Chelsea, please. So who's at risk? So we talked about how can we find out if you have blockages, listening with a stethoscope or ordering an ultrasound. Well, who needs to be listened and who should have an ultrasound? Well, those folks who have a risk of having blocked arteries. And this is a head-to-toe process, mind you, right? Hardening of arteries in your heart, hardening of arteries in your legs, hardening of arteries in your neck and your carotids. And so those folks are the ones who are smokers, those who are diabetic, those with high cholesterol, and those with a family history of cardiovascular disease, heart disease or stroke, or more importantly, if you've had a stroke yourself, or if you've had a heart attack before, in which we know that you have hardening of the arteries already. Sorry, I mentioned smoking there twice. That should be high cholesterol. And so oftentimes the folks who have this level of disease have all three or all four. They're diabetic and they're active smokers, and they have high cholesterol, and they had a heart attack in the past. Well, sure enough, those folks are the ones who we should be looking to see if you have also carotid disease. Next slide. So we talked about who's at risk, how do we diagnose? Well, let's talk about stroke. Well, how would you know if you've had a stroke? Well, we use the acronym FAST, FAST, FAST. FAST is number one, F, facial droop, in which there's asymmetry to your face, or an uneven smile, in which one side of your face droops, and when you smile, that side of your face doesn't move. The A means arm, and that arm can mean an arm paralysis, arm weakness, arm or hand clumsiness, on one side or the other. And the S is for speech. Since your brain controls your arm, your face, the muscles in your body, it also controls speech. And so the S stands for speech impairment. Listen for a slurred speech or unable to find words or garbled speech. All of these fall under the S. And then T is one of the most important things of all four of these is time. So if you see any of the F, A, or S, then T becomes important. Time. Minimize the time to alert medical attention. That's why this acronym is FAST. Move fast. Eliminate the time to alert medical attention. Call 911. And the medical services will come give attention and bring you to Mission Hospital, who is one of our only stroke receiving centers to manage strokes in South County here. Go ahead, Chelsea, next slide, please. Let's go back one. So let's say you have that disease. Let's say your doc listened to your neck. Let's say you're a smoker. Let's say you know that you have hardening of the arteries. Well, what do you do if you have that disease? If you're diagnosed with carotid artery blockages, well, simply talk to your doctor about when you should schedule an appointment to see a vascular specialist, vascular surgeon, because this blockage is a problem that can be fixed with surgery. And the treatment options for this blockage depends on the severity of that blockage, in which surgery is reserved for folks who have very severe disease, or if you have moderate disease or mild disease, then it may not require surgery, may not need me to do surgery, but rather can be managed with lifestyle changes, specifically stop smoking, control your diabetes, control your high cholesterol, and place on medicines that will help prevent strokes. And again, high-grade blockages, severe blockages would require intervention by a surgeon myself. Next slide. So what are our treatment options? Okay, so let's say you do have these blockages. If your blockages are mild or moderate in severity, based on an ultrasound or CAT scan or other types of imaging, then the first line therapy, and maybe the only therapy, may be lifestyle management, stop smoking, control diabetes, control your high blood pressure, control your high cholesterol, and then take medicines. So if your carotid disease is found early, your physician may suggest medical therapy to manage this plaque and prevent it from progressing and prevent it from fragmenting and traveling to the brain. Medicines, specifically what we call antiplatelets. It's a type of blood thinner like aspirin. There's other brands of drugs out there called Plavix. These are antiplatelets, help stop cells in the blood from sticking together and forming a small clot on that blocked artery and keeps it from breaking off and traveling to the brain. Medicines also can be used to control that high blood pressure, diabetes, cholesterol, and controlling your diabetes, your other risk factors. Your doctor may treat you more aggressively than if you didn't have known carotid artery blockages. So that's the nuts and bolts of a medical therapy for blocked arteries. And this goes the same for blocked arteries in the heart as well as blocked arteries in your neck. Next slide. Next, if your blockages are more than mild or moderate, let's say they're high grade, tight blockages, severe disease, based on that ultrasound or CAT scan or other studies, then surgery is the broad category of how we would manage that blocked artery to remove the plaque, to physically open the artery and take the plaque out of you, such that that plaque cannot fragment, break off, and send pieces to the brain. Or, as we will talk about later, placing stents. Stents is placed within the artery, and it is a wire mesh tube that will actually stabilize that plaque and push and hold it up against the wall. And we'll talk about that in a second. First off, let's talk about carotid surgery. And both of these are surgeries, stents and cutting the artery open. They're both surgeries. And so let's talk about carotid surgery in its most traditional sense, in which an incision is made on your neck. Chelsea, next slide. So here's our patient here under anesthesia. And we talked about the anatomy of where that artery is. It's at the base of the jaw, in which that internal carotid artery, where that plaque likes to form, it likes to form where that artery divides in two. Internal carotid artery, again, that's the one that goes to the brain, and that's the one that we're worried about. That plaque there is high grade, severe blockages. And we call severe blockages greater than 70% narrowing. Under general anesthesia, we prep the neck. We make an incision up and down parallel with the artery. Next slide. And the tissue is opened up and the artery is exposed. Next to the artery there is vital organs. That yellow line right down the middle there, that's a nerve. That blue circular round tubular is the jugular vein. And there's other nerves that run above and parallel to that artery. Those nerves have to be watched very carefully when we do the operation. Next slide. The artery is then clamped, so the blood flow to your brain is temporarily shut off. It's like turning the water off in the house when you're working on plumbing. And then the artery is cut open lengthwise. And this picture here depicts the plaque being shelled out. There's a clean area outside of the plaque within the layers of the artery itself, in which the plaque is shelled out from top to bottom. Next slide. And then that artery is flushed out. Make sure there's no other debris left floating around in there. And then the artery is closed, often using what we call a patch. A patch can be made of polyester. It can be made of a piece of a cow artery. We use that to patch that artery closed, and it's sewn together with fine sutures all the way around. And then those clamps, the blood flow is now restored to the brain, and blood flow is back to your brain after we're done with this operation. Next slide. The incision's closed up. It's about a 2-hour operation to this point. Patient is woken up from anesthesia and then to the ICU for post-operative care. Most patients stay overnight, and most patients go home the next day, assuming everything goes fine. Chelsea, just flip forward one slide quickly. Good. So what are the risks of this operation? So again, why are we doing this operation? Number one, to prevent strokes. So what are the benefits? Well, the benefits is again, what are the risks? So there are, as with any operation, there are risks of surgery. This one's called a carotid endarterectomy. Again, this is your traditional sense of a carotid surgery in which the plaque is removed that I just described. So it's called carotid endarterectomy. Well, what are the risks? Well, that of the surgical incision. We have to cut through the skin, cut through the artery, which includes risk of bleeding, risk of infections. That of the anesthesia, you're under anesthesia for 2 hours, and you can have a heart attack from the anesthetic. You can damage those nerves. Remember those little yellow lines that are right next to the artery? Well, those are cranial nerves. Cranial nerves are the ones that control your smile, your speech, and the motor function of your tongue. All three of these run through the area of your neck. And then more importantly, one of the risks of surgery on the carotid to prevent strokes is that the operation can give you a stroke. Why is that? Well, because you saw that we're clamping the artery and we're manipulating the blood flow in the carotid artery, and that part of the risks of surgery is giving you a stroke from the operation. That risk is all of these risks, all added together, are very, very low, much less than 1%. But as we all know, there's no risk, there's no such thing as no risk surgery. Let's go to the next slide, please. So what are our other options? What are the other options? We talked about stenting. So let's go back and review. What is the problem with these blocked arteries? Well, Doc, you said that these blocked arteries, plaque can rupture and fragment, and pieces of the plaque can travel upstream. So you either A, we talked about carotid endarterectomy, remove the plaque in itself, take it all out so it can't fragment and can't break off, or next, we can place a stent through that artery. And that stent is a wire mesh, flexible device that comes in different diameters, right, different sizes and lengths, and that's delivered over a wire. You see in the middle of the picture here, there's a little wire and a catheter on the right-hand side of the picture there. And this stent is delivered through this device, and that stent goes on the inside of the artery through the flow lumen, where the blood flows through, and that stent pushes back on that plaque. Number one, it opens the artery to allow that channel to flow better, number one. Number two, more importantly, to pin that plaque down and keep it from fragmenting and breaking off little pieces. So that's called a stent. And today we have a type of stent program that is delivered through a cut at the base of your neck, whereas traditionally stents in your heart or stents in your leg are either delivered through a puncture in your groin, through the groin artery, and traveled all through your body up to get to where our target vessel is, or it can be placed through your radial artery, the artery at your wrist, to deliver it to where it needs to be. While this TCAR, TCAR stenting is done through a small incision at the base of the neck, in which the artery is then accessed from the base of the neck to the carotid, where the carotid has disease at the bifurcation, or where that artery splits. So it's a very short runway from the base of the neck to where this plaque lives at the base of your angle of your jaw. So what is TCAR? TCAR. This is called a trancarotid stenting versus what I just described earlier, a transfemoral, going through your groin artery. This is a stenting that's done through the carotid artery to stent the carotid artery. And there's a unique mechanism of this TCAR procedure in which, while you're working, we create what we call a reversal of blood flow. So why do we need a reversal of blood flow? Say the stenting thing seems pretty easy. The problem with stenting of the carotid is you're manipulating that plaque. You're manipulating that plaque when you put in this catheter. You're manipulating the plaque when you're passing the wire through. And you're manipulating the plaque when you're putting the stent through. You're actually brushing up against that plaque. And remember, that's the problem. And that plaque can fragment while you're doing this and have little pieces travel to your brain. That's called a stroke. So in a TCAR procedure, transcarotid stenting, this artery, we create what's called a reversal of flow. You see those arrows there? The brain is up to the left. Okay? Upstream is up to the top left of the screen, and your catheter is in the bottom right of the screen. What we do is we create a reversal of flow in which blood flow is now not moving toward the brain. Blood flow is now moving toward your catheter. Okay? It's a unique mechanism in which we now pull blood backwards, such that when you're working on that artery, putting wires across, putting catheters up, putting the stent across, and you're bumping up against that plaque, any fragments that are created during the procedure is now traveling backwards. It's traveling away from the brain, and such that it protects you from a stroke while you're doing the stenting procedure. And that's the uniqueness of this TCAR procedure. Okay. Next slide moving forward, Chelsea. Next slide moving forward. So this TCAR procedure, what is great about this? Well, number one, exceptional stroke prevention, meaning that putting a stent across that artery protects you, prevents a future stroke equally as effective as taking the plaque out. So let me reiterate that. Placing a stent across a high-grade plaque protects you from future strokes very similarly to that of surgery removing a plaque, number one. Number two, it has a less risk of having a heart attack complication of a carotid endarterectomy. And the reason why is because it's a faster surgery. It's through a smaller incision. And so therefore, the risk of the anesthesia of giving you a heart attack is lower. Next, less risk of nerve damage. We're not making that 4 to 7 centimeter incision up and down that carotid artery, moving nerves out of the way so that we can clamp the artery and make an incision on the artery and remove the plaque. With a carotid stent, we make a small incision at the base of the neck, and we're not manipulating those cranial nerves that we talked about earlier, and so therefore less risk of nerve damage from the surgery. And next, there's a slightly shorter hospital stay. Most people go home, are ready to go home either late into the evening or first thing the next morning. Next slide. So, conclusions. Number one, blockages in these carotid arteries, common cause of stroke. Up to 1/3 of all strokes are caused by this blocked artery in your carotid. Number two, the blockage is often without symptoms. You and I could be walking around with carotid artery disease without symptoms. Number three, current surgical options for high-grade blockages, severe blockages, are good for prevention of stroke, preventing another stroke or preventing a stroke from occurring. And there are new techniques, this TCAR procedure, which is available with a lower risk of heart attack and nerve injuries compared to a traditional carotid endarterectomy surgery in which we remove the plaque. So speak to your doctor, your primary care, about screening for carotid disease, especially if you have those risk factors: smoking, diabetes, high cholesterol, previous heart attack, or family history of vascular disease. Or simply call me and I'm happy to take a peek at you.